Hello and welcome to the Southern Region Burn Pre-Conference Rehab Workshop. Based on feedback from attendees, the selected theme this year is casting and compression. We'll be looking at sculpting recovery and restoring function with the use of casting and compression. This year, we chose to offer a hybrid course with previewing of video lectures in an all-day in-person practicum at the Southern Region Burn Conference in October. And the pre-conference workshop is on Thursday, October 30th in Charleston, South Carolina. I'd like to recognize the people who have helped with planning this year's workshop. From the SMA, they are Randy Glick, Director, Kendra Blackman, Operations Administrator. From the Southern Region Burn Group, Dr. Jimmy Holmes, the Chair. The Program Chair, Dr. Bill Hickerson. Rehab committee members and instructors have put great effort into planning a great program for you. And they are Heather Dodd from the UNC JC Burn Center in Chapel Hill, Jenna Kelly from our host, MUSC in Charleston, Deb Knight from the JMS Burn Center in Augusta, CJ Acosta from Shriners in Galveston, and Rachel Zaloni and Lindsay Harris from Parkland in Dallas, and my rehab advisors, Jonathan Nizak and Michael Sergio.
So let's get started with casting principles for burns. I'm Donna Nakamura, and I serve as chair of the Southern Region Burn Rehab Committee. I've worked at 3 verified burn centers, the University of Washington at Harborview in Seattle, Wake Forest Burn Center in Winston-Salem, North Carolina, and the University Medical Center in New Orleans. After 4 decades in burn rehab, I no longer actively treat patients and now coordinate aftercare and survivor outreach programs at Atrium Health Wake Forest Baptist Burn Center. So what I'm presenting to you today is a combination of courses and presentations from nearly 40 years of casting experience. My disclosures include that I am a speaker consultant with Avita Medical and a key opinion leader with PolyNovo. The objectives for this course are that participants will learn basic casting principles and techniques for application and removal of casts, understand the biomechanical principles for casting for treatment of burn wounds and scars, review any potential complications when casting principles are not considered, correctly apply upper extremity and lower extremity casts for immobilization and skin graft protection, as well as soft tissue lengthening, and then experience the hands-on practice with various casting materials.
Casting is a technical skill that is easily mastered, but it requires an understanding of basic principles, and as with all skill development, practice, and more practice. Casting is a powerful technique for challenges that arise in the treatment of burn patients, but despite its effectiveness, it's seldom used as we tend to use higher tech devices and techniques. Historically, casting is a proven technique in the treatment of burn contractures. I've highlighted a few of the articles by burn rehab pioneers as Fela Helm, Mary Beth Doherty, and Robin Silverberg that document the use of serial casting. Recent studies have revisited the use of casting in rehab for conservative management of scars and contractures, for chronic wounds, and pressure for edema management and mechanomodulation of burn scars. Casts are used for a wide variety of purposes, as for rest and protection of the joint, to treat hard infield contractures, increasing passive range of motion, transferring muscle tendon unit force, increasing effective lever arm and force as a base for immobilizing splints, and to mobilize multiple joints. Mobilize a joint by blocking motion in one direction and allowing motion in another, for decreasing tone and increasing soft tissue length in spastic extremities, and for any sort of management compliance issues that may arise when using splints. So why is casting effective? It's sustained positioning that results in a plastic deformation, which will be further discussed. And this theory was first proposed by Dr. Paul Brand in his work with Hansen disease patients in India and Louisiana who benefited from the use of total contact casts to heal their wounds by offloading pressure from the feet and allowing the soft tissue to remodel. Now, casts can be used either acutely to immobilize and protect new grafts and flaps, or as a serial cast to elongate soft tissue to increase range of motion and correct early contractures. Casting provides optimal pressure distribution. It maintains the maximum tolerable end range and end range position, and thus it maximizes the end range time. The greater the end range, the faster the contracted tissue lengthens and passive range of motion can increase. Serial casting and splinting are based on the biomechanics of providing a low load, long duration stretch. Based on the principle of creep, tissue will progressively deform over time without additional force applied. And this low load sustained positioning results in the plastic deformation, which is a permanent change in tissue length due to realignment of the collagen fibers. Proposed by Reg Richard in 1998, stress relaxation is the biomechanical principle by which serial casting of a body part works to increase scar tissue elongation. It is a decrease in force that is required to maintain a piece of tissue at a given length over time. Prior to application of the cast, the patient's movement is taken to the end of its available range. And this endpoint may be slightly uncomfortable initially. However, it decreases to a comfortable level over time due to relaxation of that tissue. And so that plastic deformation occurs to the tissue that's casted for a longer duration of time. The goal of serial casting is gradual realignment of the collagen in parallel and lengthened state by constant circumferential pressure from the cast. And this plastic change is desired over the elastic response or change that removable casts create, and sort of a rebound effect, if you will. A comprehensive and extremely valuable resource was developed following the PTOT Special Interest Group in 1997 by Marlis Staley and Michael Sergio, and it was published in the JBCR in 1998. Now, some of the material is going to be a repetition of what I've already discussed, but I wanted to present the information in its entirety. The rationale for casting provides a low load or force, long duration stretch that produces a permanent plastic deformation of the connective tissue. We've already talked about that. And this prolonged mild tension results in relaxation of the attachments between collagen fibers. And so you see a gradual realignment of those collagen fibers into parallel and a lengthened state. It provides biomechanical realignment of the structures around the joint and helps to protect exposed tendons, fragile skin, or wounds. Indications for casting include any patients who have had a burn scar contracture less than 18 to 24 months who do not respond to traditional methods of therapy. Also to help protect tendons or any kind of non-compliance with patients. Pediatric patients who cannot tolerate splints or when splints are no longer effective, for protection and immobilization after skin grafting or a flap procedure, for patients who may have multiple joint involvement, and for patients with increased muscle tone. Also, to apply extra contour compression for scar management. And in the case of ankle contractures that don't respond to traditional range of motion techniques or that may interfere with normal gait and function. And also important here is that patients and families who are willing to comply with the weekly frequent clinic visits and coming back to see the burn team, and also patients and families who are willing to comply with the basic inconveniences of wearing a cast. Some contraindications for casting includes the non-compliance issues briefly mentioned earlier, such as follow-up appointments, also the ability to be able to maintain the cast and to monitor any kind of circulation or breakdown potential. Also, for anyone with excessive edema and for known or suspected HO or other sorts of bony growths, for anyone who's agitated or shows some sort of arterial insufficiency. And I have also added in here lack of training. These two photos that are on your slide here were taken by me, and it was a post-op cast used for immobilization that was applied by staff with little to no knowledge of casting principles. And this caused excruciating pain for the patient, more than usual reasonable post-op pain. And the sensory changes resulted in a nerve compression injury by the time I was called to the room for assessment. So we immediately removed this cast and fabricated a thermoplastic orthosis, and I had some discussion with that staff. Precautions for casting includes fragile skin, open wounds, although a caveat there is that casting can actually help with healing of wounds. For anyone who is insensate, but there's questionable follow-through, there's a possible allergy to casting materials. If a patient has hypertension, do not cast bilateral extremities. And again, for any patient with some sort of a cognitive or emotional state that may hinder true range of motion. So let's move on to casting materials. Basic supplies for casting include a goniometer for accurate measurements of range of motion, stockinette, and this can either be a tubular or a bias cut stockinette piece for the inner lining, cast padding, optional padding in the form of self-adhesive foam, felt, or gel sheeting, a petroleum-based ointment, the casting tape, bandage scissors, and a container for water, preferably something that is disposable or that can be lined with a plastic bag for each use. And I will get into that a little bit more later. Also gloves, gowns, towels, all of the things to keep the area and the patient protected. A pen and marker, protective eyewear for both the patient and the practitioner, and a cast saw, spreader, and scissors. So the family of casting products continues to increase, offering more options. And those synthetic casting materials were introduced in the 1970s and are predominantly used. Plaster of Paris is a mainstay for serial casting. And it's important to become familiar with the characteristics of each product to help you choose the material that will best meet your patient's needs. Plaster of Paris is basically cloth that's impregnated with gypsum, and it's readily available in a variety of sizes. It's fairly inexpensive. It's easy to mold. Because it's water-based, it can be soaked off when you need to have it removed immediately. It can be used directly on the skin, and it is skin and wound friendly. It shows the drainage and bleeding that may happen post-op. It wicks away exudate. It's breathable, and it's easier to use for smaller joints. Disadvantages or precautions include that it is very slow to cure. Sometimes a cast can take 24 to 48 hours to truly cure and set up. It's vulnerable to moisture and has poor water resistance. It's very, very messy to apply. And as long as it still remains moist, it can be very heavy. And then one of the most important things is that there is an exothermic reaction that occurs. So this exothermic reaction is a chemical reaction when the plaster of Paris and water mix. And it's important to keep this thermal effect in mind when working with patients due to a sudden increase in the temperature of the cast. And I actually have read some articles of patients sustaining burn injuries from wearing the cast. Now, generally, the cast will reach its maximum temperature in 5 to 10 minutes after the application. But variables that may increase the temperature of this exothermal reaction include a high temperatured room, such as in the operating room, any high humidity, the cast thickness. So typically we will use less than 8 layers of casting tape, undersaturation or oversaturation of the casting tape with water, the use of faster setting plasters, the dipping temperature of the water, and if any residue remains in the dipping container, this can actually accelerate the process and increase temperature. Also, any shards of plaster can incorporate into the splint and cause irritation. And if there's inadequate ventilation, and this may mean overwrapping with any cotton or elastic bandages over the cast, but it's also and critically important, especially because patients who are post-op will go to the PACU. But any cast that is covered with a blanket, like a warming blanket, or placed near a pillow or mattress will also increase in temperature. Fiberglass has a fast cure rate. It becomes rigid very quickly. It is very strong with minimal layers and very durable as well as lightweight. It comes in a variety of colors and designs, which is really fun to be able to design something special for the patient. It's not messy. It's water resistant. It can be used over a new graft, even those with some sort of an irrigating dressing in place, and it has better X-ray transmission. Disadvantages and precautions include that it's much more costly, it can be abrasive, it has a much shorter working time, there is potential for allergic reaction or skin intolerance by the patient. It will need a cast saw for removal. It has a shorter shelf life, and it can also have a higher peak temperature. So again, watching the temperature of the water used to dip the casting tape into. There are some other newer products that I personally have not used, but I do know a number of people who have used them, and you will have the opportunity to sample these products at our in-person workshop. But there is something called soft cast, which actually is applied and can be removed without a saw. As you can see, they're just cut with bandage scissors. It's great to be used together with plaster to help increase rigidity. Basically, you open the package and you have to use it completely. There's no shelf life for it. And another down point is that it can easily be removed by a patient with just a little extra tug on the product. Quick cast is elastic fiberglass mesh that's impregnated with a heat softened thermoplastic. So what's nice about this is there's no water involved. It's basically apply the material and then use a hair dryer. And let me stress that a hair dryer, never a heat gun that many OT departments have to use for thermoplastics. And this can get wet Some of them actually have some nice terry cloth liners, and I have even heard of people being able to clean their casts in the dishwasher. Gels and other padding materials, important to know that you have to be cautious of how much extra padding is added under the cast. Because too much padding can cause problems with pressure, can decrease the security of the fit of the cast, which means then increased slippage and shearing forces, and it can also contain moisture that may cause some dermal irritation or maceration of the skin. And oftentimes, extra padding is not needed, especially for a post-op splint. If the surgeons are using 10-ply burn dressings and maybe some Curlix, that would usually be sufficient padding for the cast. And types of padding that we will be showing you are self-adhesive padding or foam, some gel and silicone products, and felt strips or moleskin. So gels and other padding materials, such as gels and silicones, it's important to check the manufacturer's recommendations and contraindications for use. Some of them can be placed directly on the skin. Some of them even have a little bit of an adhesive so it remains in place. And many of them are used for softening scars, so it serves a dual purpose for both casting and compression therapy. We also have self-adhesive foams that are great for over bony prominences and areas of concern. And these can frequently be applied directly to the skin or over several layers of other cast padding. And then there's felt or moleskin, which is usually used for finishing the edges of a cast, or it can be used to help protect the skin with the patient. And especially if bivalving the cast, this is great for using as an edging on the cut surface. So what follows are some general guidelines and considerations for before, during, and after casting. Before casting, being sure to get the appropriate orders and referrals. Complete patient and family education about the purpose of casting and the process that they will be going through. And again, considering the cognitive and emotional status of the patient. Determine the joint mobility and end field. And set joints in proper alignment and stretch so that you're preparing for the casting. And do this just beyond that point of tissue resistance. And also precondition the joint and the skin just before casting. So maximize range of motion with compression or massage for edema reduction, heat modalities and stretching, joint mobilization or active and passive exercises, and therapeutic activities. Application of a basic cast. So these are the 6 steps that you'll be following when you come to your live practicum. We'll be washing extremities, cleaning and dressing the wounds, applying the stockinette inner liner, apply padding, and then apply the casting material, and then positioning the patient as desired until that casting material is set or cured. During casting, have all of your needed materials and equipment available and ready, including boxes of gloves so that you can easily reach and change out your gloves. Especially with fiberglass, the fiberglass polyurethane will get stuck onto your gloves and cause your fingers to stick together, and then you're not able to appropriately use your hands. It's important to watch all bony prominences, provide uniform contouring and sufficient cast length to avoid any pressure points. So remembering that lever arm in your physics, sustain traction force until the cast is set. Always assess skin status before, during, and after casting. By checking digits for capillary refill, temperature changes, and color changes. Assess for edema both proximally and distally to the cast. And if you have areas that you want to avoid contact or pressure, the areas can be bubbled, and we will be showing you that as well in the practicum. CAST should provide immobilization of desired points and appropriate freedom of movement for the non-casted areas. Another tip here is to hold the casting padding roll or the casting tape so that the end of the material comes off the bottom of the roll and not the top. This ensures that the appropriate pressure distribution occurs while unrolling, and so you're not pulling on the material. And this is also true for when nurses and other staff are dressing the patient with burn dressings. Cooler dipping water temperature increases the setting time, while the warmer water speeds up setting time. And again, the dip water should be clean so there's no shards of fiberglass or plaster. Increased moisture is going to delay the setting time. And consider the patient's needs for hygiene, such as showering, and they may need to cover that cast with a plastic bag. But remembering again that the plaster especially will hold in the moisture. And for pediatric patients, consider decorating the cast with some fun designs to make it more accepted by the patient. After casting, provide education again for the patient, family, and other healthcare professionals regarding the precautions, any problem signs, and care of the cast. Provide emergency contact numbers if a problem arises. And a lot of times what I like to do is just write my name and my number directly on the cast. So it's not something put on a piece of paper and put away in their pocket or something that they lose. It's important to document range, function, and skin condition immediately before and after casting. And then assess the cast after application for any shifting or shearing. Also check for any rough or sharp edges that can then be trimmed back or covered with some of the felt or moleskin for protection. And for pediatric patients, again, consider decorating the cast with what I call funfetti. In general, cast changes are done every 2 to 10 days. If you have large open wounds, every 1 to 2 days is recommended. If it's a small open wound, the cast can be left on for up to 7 days. If skin is healed, the cast can be left on for 7 to 10 days. And casting is continued until the desired goal is reached. Do not change the cast just once. And that's why we talk a lot about serial casting, because typically just one cast at one time is not effective. And following the attainment of your desired goal, recommendations are to leave the cast on for another full week after that range is attained. Some cast change guidelines. The severity and duration of contracture, the wound, and in sensory status are determinants of cast change frequency. Now, the more frequently the cast is changed, the better results due to the new end range that you achieve, and that each change you will see more tissue remodeling. Between cast changes, instruct the patient and family for at-home assessments for circulation, nerve compression, and pain from skin breakdown. In this case, the cast would need to be removed immediately if you have any signs of trouble. So again, provide the patient with a telephone number to call in case of problems. When the cast is removed, be sure to wash that area with mild soap and rinse it well. Apply any moisturizing cream to the skin and the scar before recasting. Do not use the cast just once. Change the cast and cast again. And provide passive and active movement before applying another cast. Make sure that when casting over wounds that the wound is clean and free of infection. Wash it with mild soap and water and rinse thoroughly. Apply the dressings, whether it be a petroleum gauze, foam type, or a silver dressing. And keep the wound dressing simple. Remember again that bulky dressings may decrease the effectiveness of the contour and conformity and actually allow more movement under the cast. If you find that the dressing is adherent to the wound, do not try to remove it. Apply ointment and recast them. If the dressing is not adherent, you can go ahead and remove it, wash and rinse the wound, and then apply a new dressing. You may be needing to window a cast or avoid covering a certain wound area when applying the cast, and this can easily be done, and we will be showing you this again in the practicum. For cast removal, very, very important to show the patient the cast saw and show and demonstrate to them that the blade is actually an oscillating blade that just goes back and forth versus being a rotary blade that goes around and around. And I usually demonstrate this on my own skin. It's important to mark and trim the lines. If you're making this cast into a bivalve splint, it's helpful to put a dart in it so that the patients and staff will then know just how to replace the two pieces together. Now, when cut through effectively all layers, the segments will move on their own, and you can separate the halves with the cast spreader and use bandage scissors for cutting the padding and the stockinette. Again, always inspect the skin and perform range of motion. And new small areas of skin breakdown are not uncommon. The use of the cast saw, and you'll be seeing this and being able to practice this also in the practicum, is vertical application with perpendicular strokes, doing quick and firm strokes, never dragging the cast saw blade along the edge of the cast, turning the blade to prevent overheating, and if there is thicker material, especially with the web rail type padding, the blade will get hotter. And so sometimes you need to stop and allow the blade to cool. Post-cast removal skin checks include carefully inspecting the skin and performing range of motion. Again, like I said, a new small area of skin breakdown is not uncommon and should not prevent reapplication of another cast. Adjustments may need to be made in the new cast to shift forces away from that area of breakdown. But extra padding can be added if necessary, but again, you run the risk of having more complications with additional padding. And allow time in the treatment session for a patient to stretch before reapplication of a cast. The documentation. Important to specify the type of cast and its purpose, the details of the cast materials so that it will be reproducible the next time, position of the extremity, and the expected outcome for the casting intervention. Also important to keep in mind coding and billing guidelines, as well as follow your facility guidelines and requirements. These are some of the resources, the historical ones. There are 3 pages of historical, and we will also have these resources available for you in print at the workshop. And then these are some of the current resources from the past 2 or 3 years. I thank you very much for your attention. If you have any questions, please feel free to contact me via my email that's listed here. And also, we will be having some casting experts available to help field questions during your practicum. Thank you again for your time, and we'll see you in October.